Hey guys, thanks for tuning in to Straight to the Core, an in-depth, no-nonsense look at all things physical therapy, wellness, and the business of being healthy. We are your hosts. I'm Claire.
I'm Mark.
And today we're actually talking about something physical therapy related.
Yes.
We talk about a lot of things and a lot of different tangents, but today we are actually going to give some useful information out there because today
we're talking about
something that afflicts more than 80% of people at some point in their lifetime.
I want to know who the 20% of these people who are never affected by this.
Yes.
Are they 10,
Yeah,
15?
They're newborns, probably.
Yeah, probably.
We are talking about low back pain.
Low back pain.
Yes.
Probably the number one issue that we see in the clinic, and we've all probably experienced this sometime in our lifetimes.
Yes.
Or daily.
I want to say for a while, I don't know if it's still the case, but for a while, low back pain was actually like the number 2 cause of alcoholism in the United States.
Depression, alcoholism,
Yeah.
drug addiction, prescription, medical.
Right.
Yeah, absolutely.
So talking about low back pain, and we're going to give maybe a little bit of useful information here at the end.
We hope, yes.
Stay tuned. But I think off the cuff, back pain, right? Like there's a gradient scale of back pain. You can have everyday back pain that doesn't stop you from doing anything. It's just kind of like there in the back of your head. And you can have acute debilitating back pain,
which allows you not to move,
right,
not to go to the bathroom, barely get off the ground.
Right. And can like
paralyze you.
Severely have an impact in your life. Mm-hmm. And we're talking about all of it. So, yes, the statistic is something like 84% of adults will experience low back pain at some point in their life. And I believe the statistic that I just looked up was that 95% of low back pain resolves within a 3 to 6 month period. Now that doesn't specify if like there's intervention involved or anything like that.
Or severity.
Right. And obviously there is a giant marketing space specifically catering to those people who have back pain. And we're talking about chiropractors, we're talking about physical therapy, but we're also talking about like there's stores, right, that are specifically for people to have relief or help or assistance with chairs or ergonomic assessments or mattresses or pillows or orthotics or
shoes.
Right. But I think in general, we can probably classify back pain as either like structural, and those are the big ones, right? Like disc, fracture, that sort of thing, or like a mechanical / musculoskeletal.
And I would say actually the majority of them are actually musculoskeletal.
Right.
And I will add, if you say, oh, your pain is muscle related, people think that's minimizing it. I would say for most people, muscular pain is actually worse than structural pain.
Absolutely.
Because the acute muscle spasms in your lower back are basically debilitating.
Yes. And I think that it can also be very emotional and psychological, like create a toll on that when you're having neuromuscular or muscular pain, because even though it's a hard pill to swallow, like you go in, you have a problem that's producing a severe amount of pain, you get an x-ray, you get an MRI, you get a CT scan, and it all comes back as quote unquote normal. Like that's a very, very...
It happens all the time.
Yes, that's a very tough thing to have happen when somebody is saying like, I'm in an immense amount of pain.
Well, yeah. Diagnostic imaging is not indicative of symptoms.
Right. And so I think it's probably fair to state, at least for this conversation here for the next few minutes, is that we're not talking about any of that like, hey, I fell off a horse and I have a pars fracture or I have a spondy. We're not talking about those mechanical types of pain, because those usually have a structural amount of pain. Those usually have a pretty solid diagnosis with it, right? Like something happened, there was an acute onset of symptoms, you got an x-ray, the doctor says, this is what's going on. And then you have back pain that's associated with that. Like I put that in the same way as I broke my finger hurts, and you expect your finger to hurt until that fracture is not there.
Yeah.
Right.
And I think unfortunately sometimes people get very caught up on what the MRI says. They're like, oh, I have degenerative disc disease, or I have compression, or I have a disc herniation. Lots of people have disc herniations, just like labral tears in your shoulder,
Right.
that are not symptomatic.
Right.
So those alone are not that important. But some physical therapists would say that diagnostics are not important at all. What I would argue, absolutely, they're important, but they're not the only thing that's important. Right. You cannot deny what the diagnostics are saying.
More information is always better.
Correct.
But sometimes more information is just more information. It doesn't necessarily change the course.
Correct.
So
I don't even want to talk about back surgery.
No, that's
an entirely different.
With the vast majority of back pain that we see in the clinic, and it can come from many, many different mechanisms, but I would say probably the vast majority fall into that mechanical / musculoskeletal / neuromuscular type of back pain.
Correct. And it's generally from very mundane tasks.
Yes.
It's not you're lifting something heavy necessarily, or you're lifting heavy in the gym. Sometimes it's as simple as putting on your shoes or picking up a piece of paper or just golfing and you reached for something oddly.
Right. Or timing of something. So sometimes we'll have this kind of scenario present itself in the clinic, is that you have maybe like a CrossFit athlete, or you have somebody who's going to the gym on a regular basis, and they do a workout that maybe they've done a million times before, and then they turn around and they're like, oh, I was traveling, I was in a car, or, I had to catch a flight, or I was in a work meeting or something like that. And they start to have this kind of like dull onset of pain that progresses over a day, a week, several days, that sort of thing. And so their mind instantly goes to, well, I did this workout. I must have done something in the workout, but nothing like had any red lights, nothing that immediately spoke to me of like, ooh, you know what, like I'm pushing a bad position, or I need to decrease weight. And I feel like that is something that we see somewhat common.
That's probably more common than any other type. Is it's not what you're doing, it's how much you've done over some period of time.
Right. And as a side note, with all diagnoses, but I think specifically with back pain, is that the subjective that the patient is telling you, like being able to ask the right questions, trying to figure out like potentially what's going on, and how those symptoms progress, how those symptoms first initially kind of presented, is a huge part of our job.
Yeah. I think most athletes, and even like recreational athletes, they know what's wrong with their body. They may not convey it to us necessarily super well, but if you ask the right questions, you can divulge exactly what's wrong with somebody. Mm-hmm. They know their bodies better than regular people, and even regular people generally have some idea about their bodies.
Right. Now, I think some of the big red flags that we immediately try to clear, right? Like, does it hurt when you cough or sneeze? Do you have any bowel or bladder dysfunctions? Like
radicular symptoms
right,
going down the legs.
Shooting down the leg, any numbness, any tingling, any symptoms that aren't pain. Like those are sometimes some of the biggies that we are able to kind of take care of immediately and help calm patients. If you've ever had an acute onset of pain, or even like a very, very quickly progressing amount of pain that maybe didn't start off acute, but just kind of like very rapidly progressed, then that panic sets in, and the panic kind of overrides any sort of logical thinking, right?
Correct. Like your body goes into like full anxiety mode, and
yes.
It locks you up to protect you. Mm-hmm. But if you're not aware of what that feels like, and it's your first time, you're going to be full on panic mode.
Yes.
I need to go to the ER. I don't know what's going on.
Yes.
Like I can't move.
I just had a patient actually in the clinic, 2 weeks ago, that it's been a long-time patient of mine, and he reached out kind of desperately.
Notice how quiet that was.
He reached out kind of desperately and had this trip planned. He's like, I don't know what I did. Like I woke up, I can barely move, went to the ER. I was kind of surprised that he didn't get a Toradol shot, but I mean, Toradol is like a systemic intramuscular injection that is basically a systemic muscle relaxer.
Subjectively, works fantastic.
Yeah. But he didn't, and he basically was like, I'm going to have to cancel this trip. Like I am in an immense amount of pain, and I don't know what I did. And I'm not saying that I'm like the world's best. I'm probably like the second best PT here in Omaha. We don't employ the first, but 2 sessions, right? Like we calmed this guy down. We figured out what was going on. It was muscular related. we ended up using some dry needling and some other techniques as well, like some IA stim and some very, very specific stretching, kind of like targeting glutes and paraspinals. And he went on his trip. I mean, but that just goes to show you that the amount of dysfunction that low back pain can cause. And even when it's muscular, like to your point, Mark, when you said, oh, it's just muscular, like you'll be fine. Well, no, I mean, you're talking about very, very strong muscles. That I say this in the clinic all the time, a strong muscle that's pissed off is a strong muscle pissed off, as opposed to a small, weak muscle that's ticked off that probably doesn't have that much of an effect on your body or global systems.
Yeah, I have recently had the same thing happen. Actually, somebody was going on a trip and flared up their back doing something inconsequential. They were doing a 500 to 800 mile bike ride on a motorcycle, and they were almost going to cancel the trip. And I was able to do my black magic work as per this patient. Yeah, it's not, but in a short time of treatment, you can really make some big differences in the musculoskeletal system. Calming those muscles down is fantastically simple, at least in the short term, to get somebody to really be at least functional again. Because when you're acutely spasming, you're pretty much basically handicapped.
Yeah. And I think that's probably another podcast that we kind of talk about some interventions that we use for all areas, not just back pain, but things like dry needling, things like IA stim or Graston, things like ischemic pressure or blood flow restriction, things like that you are using to manipulate how active a muscle is. Nerve flossing or nerve glides, things like that. Like being able to get mobility through an area to calm down how the nerves are talking to muscles and what the muscles are doing to the nerves, those sorts of things throughout the body. But I think even probably the most notable is in regards to back pain.
Absolutely. I think we'll do a whole podcast alone just on dry needling and how it works, and musculoskeletal pain and how it works. But I think what's important is that you look at what's happening, what are the symptoms, what are the precipitating factors, and how can you address them on an acute scale? So
with back pain, okay, one of the classic examples is that somebody bent over, picked something up off the ground. I think we're conditioned to immediately think worst case scenario of blew out my disc, right? Because of that fear of a loaded flexion.
Yeah, but loaded is relative.
Right. And in all reality, I mean, there's a ton of things that are happening every time you bend forward. Like sometimes there's lumbar flexion, but then sometimes it's mostly like a hip hinge.
Or you're rotating awkwardly to the side.
And there's some pretty strong muscles that are surrounding your back and your core. Glutes, your QL, your psoas, or your hip flexors, those lumbar paraspinals, your hamstrings, those are all kind of working together to help stabilize your spine. And so I think probably if there's one thing that I would want the 25 people listening to take from this.
Hey, that's not bad.
Is that someday we'll hit 30. Is that it's not worst case scenario on onset.
No.
Right? I think we are kind of in this point that when we hear that people have very, very bad back pain, then obviously pain is subjective, but I think we kind of take this viewpoint of, okay, let's figure out what's tight, what's causing this. And I know, I don't want to speak for you, but I know for me, I don't immediately go to, ooh, okay, is this actually vertebrae related or disc related until I get to that. It's like a process of elimination where what's the most likely cause? You hear hoofbeats, think horses, not zebras.
Yeah, I would agree. When I have somebody come in, direct access, straight to me, the number one thing that I think that everybody should remember is at least 85% of every person I see that has back pain is all muscular related. And that means that it's a fairly simple but not always easy fix.
Right. And that's not to say that obviously muscular pain can be extremely debilitating. I think
I think it's hit that. The worst type of pain.
Yes. But then also you can have muscular issues that cause other kind of trickle-down effect, which is where the term neuromuscular will come from. You can have, a very, very tight glute area compressing that sciatic nerve, and you end up getting radiating symptoms. And I think every single person who's ever, heard the word sciatica or sciatic type pain instantly is like, it's got to be my disc. I'm going to have back surgery. I'm going to be laid up for months. Like that's that immediate jump. And I even say that as somebody who absolutely is a fatalist.
Correct.
Like there is.
Well, with yourself.
Yes. Yeah, absolutely.
If Claire has a headache, she probably has a tumor. Yeah.
Absolutely. But I think also thinking that like being able to calm people almost as maybe like first line of defense when they come into the clinic. That was very quiet. Good job.
For those of you who are not watching, I was drinking my drink and not making a lot of noise.
You couldn't tell. Yeah.
And you could not hear it.
Oh my gosh.
I've been working on things. You're welcome.
Yeah.
I digress.
Yeah, I don't even remember what I was talking about there. Oh, being able to calm somebody's fear, right? Like that's a huge thing. And I know there's some physical therapists out there who are like, oh, there's no place for modalities. There's no place for manual therapy. I think there's absolutely a place for those. If you give a patient a window that they're pain-free or have decreased pain for even a small amount of time, and being able to encourage movement, encourage, blood flow to a muscle, encourage blood flow to nerves and things like that, that's huge.
I think that in our profession, there are multiple groups of people who treat differently. Some people are subscribing to that, oh, we just need to move. Yeah, that's part of it. But to say that pain science is like literally you just have to counsel somebody into getting rid of their pain mentally is ignoring the physiological components of muscular damage and spasms without realizing that those are affecting people in very many different ways.
Right. And now there's an element of pain science when you're dealing with somebody who has acute pain anywhere, is to say, trying to calm their fears. This is okay. Like I recognize that you're having pain. Your x-ray might not say that you're having pain. Your MRI might not say that you're having pain, but like recognizing that it's there and that we're going to deal with it and you're going to get better. Like that's obviously a huge psychological component to it.
Absolutely.
But I would say if you happen to stumble upon this podcast and you have low back pain, then you might be like, oh my gosh, give me some information.
Okay, we can do that.
Yes. And so I'm sure some lawyer somewhere would want us to give the disclaimer. We're not giving medical advice, right? And I even though we've covered that the vast majority of low back pain probably is muscular or neuromuscular in the aspect, like obviously check with your own medical professional. Everyone's different.
Yes.
Some of the exercises that I might give for one person that has a very specific presentation is not necessarily the exercise that I would give for someone else. So with that, moving along, we are at our home, so we cannot treat people from our home as per our license. Yes. But some great places to start if you have woken up with back pain, if you have had back pain for several times or for several days, weeks, months, whatever. Some of the things that we see, and probably one of the most common, like one of the places that I immediately check, glutes. Glute tightness, and with glute tightness comes hamstring tightness. And I know that's kind of like one of those standards that people are like, oh, my back hurts, stretch your hamstrings. Maybe. But with that, then I think you have the element of like hamstrings being tight, glutes being tight because the nerve is kind of pissed off, and the nerve is pissed off because your glutes are tight and your hamstrings are tight, and there's an element of nerve compression or decreased nerve mobility, and so it just becomes this like snowball effect, right?
Correct.
So first things first, if you wake up and you're like, well, crap,
I can't move.
Yeah. Try to stretch your hamstrings, try to stretch your glutes.
Glutes probably even more than hamstrings.
Yes.
Hamstrings are 2 joints away, essentially, not quite, but a bigger aspect of the compression of any back issue is coming from your glute first. Agreed. Because it's much closer to the lower back than your hamstrings are.
Agreed.
And it's a very strong muscle group.
I don't love everything that he comes out with, but the physical therapist that kind of made a name for himself through CrossFit, Kelly Starrett, yeah. Huge group of eagles that just flew by.
I didn't see them.
A ton
God bless
of
America.
America.
Yeah. Okay, I digress.
Anyway, Supple Leopard, then he's since like revamped himself as being, I believe it's the Ready State, his like Instagram handle now.
Yeah.
Anyway, check him out if you want to. I don't love everything that he does, but one of the things that he kind of like popularized was using the term like smash in regards to muscles. So I use the term ischemic pressure in this, especially with glutes.
That's what it is.
Right. So the example that I give people all the time, and if you've been in the clinic, you've probably heard it, and sorry if this is like the 12th time that you've heard it, but essentially when you are outside and it's really, really cold and your hands get kind of like white and the blood flow is obviously not going to your fingers because it's so cold that your blood flow is kind of being shunted back to your core to keep your vital organs warm. Then when you go inside, if your hands heat up very rapidly, then it almost gets like a burning sensation. And that is the element of blood flow control, right? Like you are shunting blood to or away from an area. It's blood flow restriction, blood flow control. So something like ischemic pressure to an area like your glutes that are super, super tight is you're taking a ball, a foam roller. Lacrosse balls are super popular because they're cheap and they're relatively easy to get to, but obviously you can use like a tennis ball. You can use a foam roller. You can use the handle of a kettlebell. You can use a softball. Like you really could use like a dog toy too, but cat toy. You're basically trying to create pressure in an area to decrease blood flow with the thought that then when you release the blood flow restriction, then that blood flow comes rushing back into that area and it makes it easier to stretch. And so Mark and I will both do something in the clinic similar to this with a lacrosse ball to have people kind of manipulate blood flow in and out of that glute area.
Yeah, the glutes are the number one component to almost every back pain that I see.
Your glutes are the base of your spine.
It is I usually say this all the time, that you can have a strong back, but that's like a house. But if your foundation, your glutes, aren't really up for the task, it doesn't matter how well built your house is. Your foundation with the glutes is the most important component of back health.
I had a boss once, like honestly, like forever ago in a different lifetime, that straight up laughed at one point when I had said being able to strengthen your back. And the thought was, oh, you can't really strengthen your back because your back is bone and your back is ligaments that's holding it together and nerves. And you really have to err more on the side of having mobility, which I do think mobility is a huge aspect.
Huge component.
Yeah. But if you ask somebody to help you move, or you ask somebody to like, hey, in the clinic, sometimes we have to like clean up underneath the treadmill. And so we have to pick up the treadmill. I'm very often up for that task because I lift, and that's an entirely different topic as well. Like sumo deadlift versus conventional or God's way. But what's more functional? But because I happen to sumo deadlift, then me getting into a sumo deadlift position to pick something up is just another day at the gym. Right. Mm-hmm. But if I ask somebody to pick up a 500-pound treadmill or lift up a portion of a 500-pound treadmill and they've never deadlifted a day in their life, there's going to be there's
a problem.
Right. And so that's where I think that, to your point, how you said it perfectly, you can have the strongest, most well-built house, but if your foundation isn't there, it doesn't matter.
Correct. And I think a lot of diagnoses come back from like your family practice doctor is, oh, you have a weak core. Mm-hmm. I know a lot of really strong people that have very little weaknesses that have back pain. Mm-hmm. It's not just a weakness problem. Sometimes it's a mobility problem. Sometimes it's a weakness problem. Sometimes it's an inability to figure out how to move correctly. There's a lot of variables there. But to say it's just a core weakness problem, that's not always quite that simple.
Right. Now, I think probably second to glutes and then by default hamstrings being tight, that I would tell somebody who has like an acute onset of back pain or just wants to try something different. I would say the mobility aspect, not only of glutes, but of hip flexors.
Correct.
We're a society that sits now.
A lot.
And, even if you don't sit a lot, sometimes it's the timing of sitting. The classic example of someone who who runs the Lincoln Half Marathon or Lincoln Marathon and then hops in a car and sits for 45 minutes on their way back to Omaha. And then all of a sudden they get out and they're like, I can't get out of the car, right?
Yeah.
Like you're back here. Because you sat as things kind of like cooled down and tightened up. That's just how our bodies work, right? Then as things tighten up, sometimes you're not in the most ideal position.
Nope.
And hip flexor tightness, and I'm not of the thought that like sitting is the new smoking. I'm not that person. But I think hip flexor tightness, if you don't do anything to counteract it, can definitely be an indicator of back pain as well, or a huge component of it.
Yeah, I would agree. Actually, I think that besides the glute tightness, I would say the hip flexor weakness is a huge issue. And I think a lot of tightness in the hip flexor region itself comes from weakness, because a lot of the very popular lower body exercises do not touch the hip flexors.
Yes. And I would also say somehow there was this thought that like, oh no, I can't sleep on my stomach. That's bad for your back. I don't know why. Like I enjoy sleeping on my stomach. It's a good nap position for me. But we don't do a lot of things as an adult laying in that prone or on your stomach position. Right?
Not a lot of tummy time. No.
Yeah. And you think about when you're a kid, you sit there and you just like, you're laying on your stomach and you're propping yourself up into a tiny little bit of lumbar extension, or you're sitting there watching TV in that position.
I mean, I used to play video games in that position with a controller, just laying on your stomach. Adults
for hours on end.
Rarely get in that position.
And so I think that even if you take the stance that like, okay, yeah, you can sit, like maybe you have a desk job. Are you doing anything to counteract that?
Yes. For every reaction, there should be an opposite reaction, and you need to get into the opposite position.
I'm probably not that kind at the clinic sometimes, is when people are like, oh yeah, no, I would love to sleep on my stomach, but it's bad for your back. And I always just say like, oh, why?
Well, it's bad for your back because you don't have enough mobility to be comfortable there. It's just like saying, I can't squat to full depth because my hips are tight. Well, they're tight because you're never there.
Right. And this falls into that category of like, we're not giving medical advice. Because honestly, if you have some sort of like vertebrae fracture, like I'm not going to tell you to do a ton of tummy time because you want to kind of like stay away from lumbar extension if you have like a spondy.
Well, of course, it's all relative and it all depends.
But if that's one of those things that you can try. I mean, if you have some debilitating back pain or even just like progressive like low back soreness, low back tightness that you're just like, why is this like a constant in my life? Even if it doesn't necessarily like interact or have a negative impact in your life, it's just there, right? Then having some tummy time or having, hip flexor mobility, getting into kind of like, I know the couch stretch is kind of popular, but like kind of a little lunge position, stretching out that hip flexor. Having some hip flexor strengthening to your point that you said we don't do a lot to strengthen that area.
Most athletes don't do any.
Increasing blood flow to that area, doing something as simple as like a march or a lunge just to get some blood flow going to that area. I think that could be huge.
Agreed. People just don't understand the mechanics, and that's fine. That's not your job, but go see a professional if you're having pain. Mm-hmm. It will behoove you to do so.
Yes.
You can solve problems much quicker, but just make sure you're going to the right person.
Yes. And I think probably the third, probably of three, most important thing is moving. Like
you have to move.
Yes. And I know there was this kind of thing going on in the PT world maybe like 2-3 years ago where that mindset of let's get people moving somehow got like overly simplified into like, oh, if you have back pain, just go for a walk each day. Like that's okay. The intention is good. And I think it just got oversimplified is that there's so much fear, and fear avoidance is around for every injury for sure, right? Like the classic, oh, I hurt my shoulder, so I'm gonna hold my arm like this, or I hurt my neck, so I turn with my whole body, and then that just becomes your movement pattern. Fear avoidance is around all the time, but I think more so with lower back in the sense of, obviously if you have back pain, you don't want to do anything to make it worse because it can be so debilitating. But then you have people who are like, well, nope, I'm not going to go to the gym. I'm not going to do these regular things. I'm not going to go for a walk around the neighborhood. I'm not going to try laying on my stomach. I'm going to lay on my back and I'm not going to move. And now not only have you decreased your activity level from, potentially aggravating things, but you've also taken all movement out.
Yeah. And so your lower back is not like an ankle sprain. Sometimes you need to rest your ankle, but you still have to move it. Movement is, unfortunately, medicine, and controlled movement in the right planes of motion is a great way.
Do you want to say it or did say it?
I think you should say it because you say it all the time. I'm not saying it.
Motion is lotion.
Claire says this all the time in the clinic.
I do, and
weird.
I always give the statement that I hate saying it. It is just like an icky statement, and it's old school, and it makes me sound 80, but it's so true. Like, motion is lotion. The more that you move, the more that your body wants to move and wants to allow that movement to happen.
I would agree. I think one of the biggest preventative things for back pain is getting your body to contract its muscles in all planes of motion that you wouldn't normally use will be very preventative, including lumbar flexion, lumbar extension, rotation, all types of positions that you may or may not encounter in your lifetime. But the problem is, if you're only like strengthening in straight planes and then you get in a weird position, your body's not aware of what you're doing, so it doesn't like it. So it might just freak out and decide that you're going to have a really bad week.
There is a particular type of deadlift. Is it called a Jefferson?
Yeah.
Yeah. Where, and I'm not even necessarily sure that you should do this with heavy. You absolutely shouldn't do it with heavy weight. But the idea behind a Jefferson deadlift is that, yes, there's a hip hinge in there, but you're purposely allowing lumbar movement to happen with it.
Into lumbar flexion.
Yes.
And then to a degree that you shouldn't be doing, but sometimes life will put you there anyway.
Right. And so while I disagree with doing it heavily loaded, then, the idea of trying to get your body into these positions that you're probably going to find yourself in anyway at some point in your life, so that everything isn't this like new, novel, potentially dangerous position. I like that.
I like it when people do mobility training with light resistance in all awkward planes of motion.
Right.
Because
And
that gets your body used to weird stuff.
Yeah.
And that's what happens in life. It's not the heavy stuff.
Absolutely. It's the small things. It's not deadlifting. It's picking up the towel off the ground.
Yeah.
Afterwards.
When it's the morning. You're in a hurry. You're not in position. You pick up like your shoe awkwardly and you're like, oh my God, I can't move now. What's the deal?
Yeah.
I'm weak. No, it's not a weakness problem. It's a position problem, or it's a mobility problem.
Yes, I agree. So I like that. I like it from the aspect of like, you do have to get your body used to some of these like weird positions and awkward positions, because that's life. Life isn't perfect.
Especially if you're incredibly tall or if you're incredibly short.
Right.
You have to like curtail your mobility program for that.
Right. But I also think that having body awareness of when those positions are awkward, right? Like being able to train a heavy deadlift, because in my job, I am lifting and moving and manipulating people's, limbs, and I'm a small person. I'm a small sprite of a lady.
A lady?
Yeah. Yes.
Okay.
Then I have to do that, right? But then I also am aware, because I lift, and when I'm doing something like a deadlift or a stiff-legged deadlift or an RDL or something where I'm specifically kind of focusing on stabilization, then I also am very aware of when my body's not in those positions. And I think that's a big part too.
Yeah, I think there's a lot of factors here, and it's really hard to talk about all of them on a podcast because it depends.
Absolutely.
And
That's the classic answer
it does.
in medicine, is it depends. And people want absolute, like we had a couple of people be like, yeah, give us the top 3 exercises that when you have back pain. It absolutely depends, right? But safely, I think checking glutes, checking hamstring mobility, checking hip flexor mobility, and just getting some movement.
Yes.
Would be my take home point that I want.
Yeah, bridges,
I want our 12
lateral
subscribers
trunk
to-
rotation, and extension of some sort to get things to calm down.
A modified pigeon pose, big fan of.
Yeah, hip flexor stretching.
Yep.
Gradual. Make sure your glutes are engaged so you're not hyper arching your back.
Right. I'm a big fan of like a kneeling lunge with a little overhead reach.
Yeah.
Get a little psoas in there, get a little QL in there, get a little hip flexor.
Do a little rotation at the pelvis so you can get some side flexion in there so the QL is more involved.
Yep. I don't hate an inchworm.
Everyone hates
Well,
inchworms.
to be fair, yes. I don't hate prescribing an inchworm.
No, it's fantastic.
Yep. It's a little nerve glide. It's a little glute stretch, a little hamstring
Heck
stretch.
of a calf stretch for most people,
Yeah.
sadly, too. But then you're getting core stability involved. So the inchworm is very underrated.
Yes. I love it. I love it.
I love it. but
Now that I think as a last point, I do like to point out that both Mark and I have had an experience of fairly debilitating back pain.
some more than others.
Yes. And I can very honestly say that I have never, knock on wood, had my back pain come from doing anything in the gym. Specifically, well, I mean, like I've actually hurt my back picking up a towel when I was at the gym,
No,
but
it doesn't count.
I've not had something where I was pushing a bad position and felt like, wow, now my back feels like trash.
I would agree. I think in my lifetime, I probably had more than I would care to admit exacerbations of acute low back pain.
Mm-hmm.
At least 90 to 95% had nothing to do with the gym.
Yeah.
And it's primarily in the morning, awkwardly moving, and you're stiff, and your mobility is an issue. And I have generally very good mobility for somebody my age. But as I've gotten older, I spend less time in those positions. And I think it's important as everyone gets older, you get yourself into positions of flexion, extension, side bending, and rotation often enough that your body does not see that as being a new position.
Right. It's not threatening. It's not novel. It's not.
It is a comfortable position.
If you've been in the clinic before, then first off, you know that I'm constantly searching for a step stool that we have underneath the tables. We should just buy more. But and the other thing that you probably notice is I'm up on the tables all the time, which is kind of weird when you're a new patient because I'm like, oop, okay, make some room for me. But I'm short and the tables are a fixed height. We don't have adjustable tables because they're not as sturdy or stable. And so I get up on the table because I am not going to be trying to produce force or pull or push when I'm kind of out of position. And I think that that also comes down to body awareness with low back pain, not like kind of chronic low back pain, but kind of more of those acute aggravations of it, is that when you start to move through different planes and through, like Mark said, like incorporating twisting and moving and bending and things like that, then you start to not be as scared of those positions. And it makes it even more obvious when you're in those positions that you're like, ooh, that's not good. Right? Like I can sit there and I can stretch someone. Maybe I'm doing like a hip stretch and the first 2 reps of it are fine. And the third one, I'm like, oh yeah, I feel that in my lower back. I'm gonna hop up on the table. I don't care if it's awkward. Like it's not awkward for me.
Yeah.
We're gonna get real friendly.
Yeah. I think there's a whole podcast upcoming on preventative of lower back pain, which will be more interesting, but you have to be at a baseline of being relatively pain-free before you start getting into the strengthening and prevention.
Yeah.
You cannot prevent things that you're currently in.
Yes. But so take home points for, our 12 current listeners.
25.
Yeah, 25 subscribers.
Oh, no, it's more than that. We have...
No, that's downloads. We have like 25 people who...
Okay, I disagree, but that's fine.
Okay, well, thank you, everybody, for listening. But take
It's
home
a solid
points.
30.
Yes. Move. Don't be scared. It likely is going to resolve. Check your glutes. Check your hamstrings.
Hip
Get yourself
flexors.
moving. Check your hip flexors. Call Mark and Claire.
See somebody who knows what they're doing.
Yes.
Also another podcast. How do you know if your medical professional is really good at their job or not?
And somehow if you stumbled upon this podcast or this YouTube video and you are not in the area, then hopefully we at least gave you a little something that if, Murphy's Law, your car goes out Saturday afternoon, or like you hurt your tooth on a Saturday morning, you can't get it at the dentist until Monday. Hopefully this is something that gave a little glimmer of hope, a little like window of, okay, here's something that I can do to treat some back pain.
Back pain is common. Most people will have it sometime in their life. I have a hard time believing that not everybody has back pain at some point in their life, but
before we end, and this will be the last thing that I say because it's a touch controversial.
Oh dear.
I say this often. Well, I shouldn't say I say this. I ask this question often about people who have acute low back pain, and I say, does alcohol help? And people are like, well, alcohol helps everything. Agreed.
Alcohol is a solution.
But the reason that I ask that question is because alcohol systemically is a fantastic muscle relaxer. And I know a lot of people do not like the idea of taking a muscle relaxer because honestly, the best thing that a muscle relaxer does is it cures consciousness. You like that?
Yeah, I do.
But the reason that I ask that is then to help calm people's fears. As I say, if not talking about like getting smashed on a Saturday night and ruining your Sunday. I'm talking about if you have a glass of wine or if you have 1 or 2 drinks, does that take the edge off of your back pain? And very often, if it does, it means that there's a huge muscular component to it. Correct. Because of the muscle relaxation effect of alcohol.
Correct. Saturday night smashing is different to different people, so be careful how you use that term.
No, I said getting smashed on a Saturday night.
Have you seen Jersey Shore?
The t-shirt before the shirt.
There's a smash room. Okay, so be careful how you use that term.
You've now dated yourself.
I would very much get along with myself if I were dating myself.
Gross. Anyway. Yes, so that would be my last parting shot is, you know what? Like if all else fails, maybe see how your symptoms are after 1 drink, if you are of legal age, and take some relief in the fact that if 1 drink does help your symptoms, if you are of legal age, then it's probably a muscular component of it, and you will get through this. You will get over it. You will get better.
Yeah, it's pretty rare that I would see somebody for a chronic situation where there's no relief in sight. That is extremely rare. Yes. And that usually involves a trauma of a motorcycle accident or a terrible car accident or somebody fell like 30 feet. Unless you're one of those people, the likelihood of it resolving at a very high level is extremely high.
Yes, agreed.
Yeah.
Yeah. So hopefully you got something educational out of that.
I mean, this is a very complicated topic. I feel like we could talk about any one of these avenues multiple times.
Absolutely. But if all else fails, then hopefully that gave you a little bit to get yourself through a period of time until you can make contact with a medical professional. And if you want to come see us at the clinic, let us know.
We treat this all the time.
C.O.R.E.Omaha.com. We're on Instagram, C.O.R.E Omaha, Facebook, C.O.R.E Physical Therapy and Sports Performance.
Oh, hold on. Say it again.
C.O.R.E Physical Therapy and Sports Performance. I don't believe we have a TikTok.
Yeah, I'm not into TikTok.
We don't, yeah.
Too much technology.
But you know what?
I'm a low-tech kind of guy.
If we do some shorts, then I'll let you know. I will tell people all the time to try to sound cool. I'll be like, oh, I was watching a TikTok. No, it probably started on TikTok, and then 2 months later, it made its way to Instagram when I actually watched it.
It goes right to YouTube.
But so check us out. As always, if you guys have any questions, like feel free to shoot us an email, leave a comment below here on YouTube. If you're listening to us on Spotify or Apple, then yeah, you're gonna have to send like a carrier pigeon to us. But ask a question, reach out. We're always happy to help.
Yeah, and if you have questions or things that you want us to talk about, we love suggestions. We often ask this at the clinic.
Absolutely.
We've got lots of topics coming up. So yeah.
Well, I'm Claire.
I'm Mark.
We're C.O.R.E Physical Therapy and Sports Performance. We're out.